Good morning. Sorry for that delay. This is a wonderful opportunity, and thank you so much to the organizing committee for having me. I know the audience is large and diverse with an incredible skill set in chronic pain, and I hope that you will feel comfortable entering thoughts or questions into the chat, and certainly at the panel discussion, I hope that we can speak further on this. This is a massive topic, actually. Chronic abdominal pain is certainly a challenge, and I hope to just give you a general overview about this, and then we can discuss further in the panel discussion at the end. So I don't have any disclosures for this talk this morning. I hope that I can explain a little bit about the pathophysiology of chronic abdominal pain and speak specifically about visceral hypersensitivity, a term that you may or may not be familiar with, talk a little bit about both rare and common factors and etiologies contributing to abdominal pain, and then talk a bit about some evidence-based strategies and some tools that we've developed in collaboration with primary care to support patients both in the medical home and in specialty care. So this is no news to any of you. A chronic abdominal pain is incredibly common. And when I just quickly did a search on Google, I got 302 million hits. And when you try to sort of stick handle all the information online, I can imagine from a patient's perspective, there is a lot to try to digest, excuse the pun. So we've got just a snapshot here of all of the different ways in which folks can try to navigate this sea of information. And then they're going to come to many of you to try to get some insight into their chronic abdominal pain. I think before we go into some of the details around investigation and pathophysiology and etiology, I think we have to really drill down to the very core of pain and nociception in the gut. So this is a complex diagram, and I appreciate that. But if you look in the left side of the screen, where you see the hollow viscus, which is basically the tube of the gut, you can understand a little bit about visceral stimuli and visceral sensitivity. So it's very different, as you are likely well aware, than somatic innervation and nociception. And it's much less specific. So what's very important is there's two different types of ways in which pain stimuli is communicated in the gut. One is stretch of a hollow viscus or the tube, and one is chemical. And these pain receptors are both in the wall of the bowel, on the serosal surface or the outside layer of the bowel, and also within the mesentery. So there's lots of potential different inputs that can then be transferred through the dorsal root ganglia and then into the brain, and specifically the pain reception areas. If we think about the inputs from the spinal cord, and thus centrally, we can see from T8 to T12. And what's also very important, in addition to the visceral nociception, it's also somatic with the abdominal wall and different aspects of the abdominal wall. And we'll think about this and get into some of the details of that in a little bit. So when a patient presents to us, certainly in specialty care in gastroenterology, and for sure in primary care, and they describe, oh, I've got terrible abdominal pain, one of the ways in which we try to anatomically understand it is by breaking the belly down. And so there's a couple of different ways in which to do that anatomically. And obviously, the epigastrum or upper abdomen is a very common place for abdominal pain. And then periumbilical or centralized abdominal pain is also important to understand, again, the underlying drivers. Some patients just have generalized abdominal pain, and it's very difficult to localize it. So it's just the abdomen in general. Pelvic pain, again, is something that's very complex and important because there's etiologies that contribute to pelvic pain that might not be gastrointestinal. And then, very importantly, the right upper quadrant and the biliary system and the liver and the pancreas, they can all actually radiate. And with referred pain, patients can actually describe pain into their back and into their shoulder tip. So when we're describing pain and guiding patients in their delivery of their description, it's really important that we try to try to localize the pain into focal areas of the abdomen so we can anatomically try to understand the etiology. One of the things, again, to further the location is to really get a description. And this is all old hat for you. And this is really sort of what we would teach a medical student about the description of chronic abdominal pain. And I think the real key is to try to get that sense of the chronicity. And one of the first things that I ask patients who have chronic abdominal pain is we talk about childhood and we talk about missed school and the impact on their life and how it actually has influenced them over the very long term, because we're talking about chronic pain. We've talked about location. We need to talk about onset. Has it been present intermittently? What the pattern is? Radiation, again, some of the comments I made about the back. Certainly chronic pancreatitis can radiate into the back, into the shoulder tip. And then other exacerbating and ameliorating factors. Is it related to food? Is it related to pooping? And then obviously very important, other systems that can be involved. Medications are super important, and I've highlighted non-steroidal anti-inflammatories here. This is a GI doctor's bane because we run into a lot of trouble because of this category of medications, but we also recognize how great they are for controlling pain. Another big category that I know is very important for maintenance of chronic pain, but is also problematic, is narcotics. And they are in particular challenging because, as you well recognize, they slow down the motility of the gut. And then when we try to back off or reduce the dose of narcotics, you can have a rebound type of hypersensitivity reaction. So abdominal pain and narcotics is a complex dynamic, one that takes some time to tease apart. One of the important additional factors is when the chronic pain had its onset. So certainly this is in the context of, as we age, as you well recognize, we're more concerned about malignancy. So after age 50, this is the year after which we really are vigilant about colorectal cancer screening. So we tend not to negate that time frame and really focus on their risk for malignancy. Travel history is important. Certainly past history of gastroenteritis and intestinal infections is important. Contributing factors to pancreatitis, alcohol being one, and alcohol is an important one just for the overarching mental health history, addictions history. We're going to talk a little bit about trauma in a bit, and I don't have to emphasize the importance of trauma history and individuals' propensity for chronic pain and chronic illness with a significant childhood or past history of trauma. You're well aware of that, but that's a very important one for abdominal pain. Family history, which goes without saying, which we've already addressed with age of onset. Medications we've talked about, and then other environmental factors may very well be important. Red flags are clearly important, well known to you. These are issues that we certainly in the medical home, primary care and specialty care really focus on. Nighttime habit is important, bleeding is important, anemia and abnormal blood work. I never like people to have to wake up at night with either pain or defecation. One of the things that patients often request and are interested in very appropriately is a battery of investigations. And I think this issue is important to talk about because investigations are important to put into context of their history, both of their history of abdominal pain and past history of investigations. And there's a very delicate balance that we all must strike with furthering investigations as opposed to identifying chronic pain syndromes that will not actually be identified or further illuminated by various investigations. So what's really important is to reflect on their pain history, as I've outlined, and then look at the investigations that have occurred to date. And certainly there are altogether appropriate investigations if these have not been undertaken, and certainly in the context of trying to understand any presentations of red flags, as I've outlined. There's lots of investigations, and I would start with ones that tend to be a bit more non-invasive. Imaging is very good and important and can give us a lot of information. Blood work can send some very reassuring signals of, normal iron stores, normal nutritional indices, normal CBC or hemoglobin, and other blood counts like platelets. I'm not sure how many of you are aware of this poop test that is now available in Alberta called 𝐒𝐔𝐁𝐄. This is a non-invasive test where we actually look at a neutrophil produced or white blood cell produced protein that is heat stable, present in poop when there are neutrophils present or inflammation. It's very useful for looking particularly at colonic inflammation. And so we're using this test as a nice screening tool to eliminate inflammation present in the colon as a driver of chronic pain. And then endoscopies. And what happens sometimes when people have chronic pain is that they keep coming back for endoscopic examination, which, as you know, is invasive. Patients have to miss work and school and their usual activities to prepare. They have to have sedation. And it is an incredibly costly and time-intensive resource, and we want to use it to the very best of our abilities. And in lots of these circumstances, it actually doesn't help us get any closer to the etiology. So it's just something to keep in mind that endoscopy has limitations, and I think it's really important to communicate this to patients. Now, I put this slide up in parentheses, really, if you will, because these are incredibly rare. I think sometimes in specialty care, for sure, we're motivated to ensure we've excluded all of these entities. But I will tell you the vast majority of patients that present to specialty care and gastroenterology with chronic pain syndromes do not have any of these, and they're very common entities. Probably 40% of the consults we see in general gastroenterology that are visceral hypersensitivity in origin. So these are elements that are non-contributory most of the time. Now, there's an interesting abdominal wall syndrome. So when the pain is localized, we can certainly do some really easy tests to try to identify nerve entrapment or some type of process that can actually impinge on abdominal wall nerves. And these are very easy to treat. And this is a simple bedside maneuver that a doc or a provider can do by lifting the patient's head off the bed or their legs off the bed, which then contracts their abdominal muscles, their rectus muscles, and then the patient feels this very focal, tender spot, and we can move from there with lidocaine injections and various things. So it's not inside their body at all. It's not luminal. It's not anything but a focal problem in the abdominal wall. So an easy exclusion. When I was asked to do this talk today, chronic pancreatitis came up, and this is something that's very common in Google searches, and you'll often see patients on supplemental pancreatic enzymes in order to augment digestion. Chronic pancreatitis as an entity itself is actually not very common, and it's usually an entity that is preceded by recurrent acute pancreatitis. So without that as a precursor, chronic pancreatitis is actually quite infrequent, and it can be investigated with imaging. CT scans and calcifications present in the pancreas are a suggestion of that. Endoscopic ultrasound is also something that we do. This is a disabling condition, there's no doubt, and often results in the need for celiac plexus neurolysis because it is so disabling. But in my career, it's actually quite rare and usually, again, preceded by acute pancreatitis. So once we've got all those other entities sort of out of the way, we're left with a really big category of chronic abdominal pain that occurs again in different parts of the abdomen. And docs will often refer to these as functional gastrointestinal disorders. And when you take a step back, you think, what the heck does that even mean? So what it means to me is that it's the function of the gut that is actually abnormal, and the motility and the communication of sensation that's dysfunctional. But we're moving away from this sort of non-specific term because it doesn't make sense to patients and it doesn't resonate as far as the underlying pathophysiology. So there's actually, it's quite a mouthful, but there's a move towards this term disorders of gut-brain interaction, which I think is really quite a much more insightful way of describing this very complex entity. The three most common types of DGBIs are and include irritable bowel syndrome. Many of you are familiar with this, up to 15% of North American adults. Functional dyspepsia is very common, tends to be epigastric in origin, around 20%. And something that actually is quite a bit less common, centrally mediated chronic abdominal pain syndrome, at most 2% of the population. And we can talk about the complex etiologies there. Now, where do all these terms and identifying the different entities come from? Well, very specialized groups of mostly gastroenterologists and some psychiatrists who love to eat pizza, I think, and meet in Rome, which started in 1988, all the way through to Rome 4 in 2016. And this is really academic and irrelevant, but if you come across these sort of criteria and naming kind of norms, they stem from this group of expert adults that really has multidisciplinary input, both from GI and psychiatry. Now, recognizing that there is a lot of impact, cost, quality of life, and significant patient experience concern given chronic abdominal pain, we have worked closely with primary care in gastroenterology in the Calgary zone and actually are working very hard provincially to implement these pathways so that providers have access to these pathways across the province. But this pathway is available through the specialist link website. And so you just have to click on it. And all of these are active links. So you can click on any of these, the expanded detail, physician or NP or provider resources, in order to follow this algorithm. And this is really a starting point to try to follow the road towards understanding chronic abdominal pain. And so I present this to you as a very important resource for providers who deal with chronic pain so that we can together help patients navigate this complex pathway, because a multidisciplinary perspective is very important. So I'm going to leave this for now and we're going to walk through this a little bit. But this is a stepwise algorithm to help guide both the etiologies, investigations, and then principles of treatment. So it's very straightforward with an expanded detail of evidence-based literature to support each of the elements. So where do we start in management? Let's say we have a patient, mid-30s, pain since adolescence, lots of missed school, long-standing diagnosis of irritable bowel syndrome, mixed, which means their defecatory pattern is both constipation, altering with diarrhea, really has not had a lot of success in finding a pathway towards wellness, frustrated, recurring primary care visits. You look back in neck care and they've been to emerge probably 6 times in the last 3 years, really not progressing as far as quality of life and symptom improvement. So I don't have to tell this audience by any stretch, one of the most foundational starting points with patients who struggle with chronic abdominal pain and stool pattern alteration consistent with irritable bowel syndrome and other pain syndromes is to really listen and validate. So I think this is probably the single most important part of the patient provider interaction. And I know this is well known to you, but I think my colleagues we really need to take a step back and understand this component, because I think the validation and recognition of the disability of these conditions is very important. We did a series of focus groups a number of years ago with patients with irritable bowel syndrome, and the messaging we got from some was as significant as, well, it would be a lot easier if I had cancer. At least then I would have something. So I think this idea of this functional, abdominal pain or functional gut disorders has the perception or the experience from patients that this isn't real, this isn't legit, you don't have an organic condition. So we have to walk back from that in our conventional medical system and redefine it, validate it, and recognize the disability that patients experience with this. I just want to touch on trauma, certainly very briefly. There is increasing documentation, and you are all very well aware of the history of trauma and how it predisposes individuals to chronic conditions of a myriad of origins, and chronic pain is certainly a very important condition that patients experience, and chronic abdominal pain is a very important one. And I know that this is a whole talk in and of itself. And when we think about whether it's sexual trauma or myriad other types of trauma, this is very important as we engage the health system and even think about things that are commonly performed, like endoscopy, that we have to be much more thoughtful of and trauma informed in order to make sure that patients have an experience that doesn't re-traumatize them. So I know there's probably individuals in the audience that are experts and much more experts than myself in this, but I think this is increasingly becoming aware, certainly to specialists and to primary care providers, that this is very much a part of the foundation of therapy and of treatment, that this needs to be addressed going forward. So I'm nearing the end and look forward to our chat soon. One of the most important parts of therapy is that it's multidisciplinary. So we all need to come together to wrap our services around patients with chronic pain, as you are all expert in. And one of the other really important strategies that I'm sure you would agree with me with is empowerment and enhancing patient self-management. So this is a collaborative effort, again, by primary and specialty care to develop a patient-facing algorithm to walk them through chronic abdominal pain. And this will have a robust input from patients. And I put it out to you. I would love for anyone who is interested in participating in giving us some feedback on this working document, both from yourselves as expert providers, or if you think there's patients that you think might be able to give us some great input, we would just love your participation. But this is a tool in which providers can help patients take some ownership and participate in their self-management as they walk through the algorithm that goes with the provider-focused algorithm. So what are the elements of management? Well, again, there are many for chronic abdominal pain, and I'm going to leave out some of the other entities that we talked about earlier that are both more rare and more focal, like abdominal wall pain. This is really for those patients with disorders of the brain-gut axis. So at a very foundational level is dietary interventions and collaboration with nutrition support and nutrition therapy is very important. And within Alberta Health Services, we have a number of resources for this. There are lots of different diets. And again, in that 302 million Google hits, there are as many, if not more, for nutritional support. So helping patients navigate that can be important and challenging. Certainly in GI, we use a lot of FODMAPs diet, which is a mouthful, and hence the acronym, stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And in essence, these are short to medium chain carbohydrates that act as effective osmoles in the gut. So they can cause things like air production, gas production, diarrhea, altered bowel habit, bloating, etc. And there's increasing evidence to suggest that these diets are very effective for long-standing both dyspepsia and irritable bowel syndrome. So at the very heart of an approach to chronic abdominal pain and syndromes therein is really a very careful look at the diet and excluding triggers. And I recognize that not everybody can afford or has access to, such a beautiful array of fresh produce and healthy foods. And this is something that together we have to help patients navigate. So looking again around the circle, we certainly think sleep is an incredibly part of health overall and can contribute to abdominal pain and really overall coping strategies. Exercise is increasingly recognized as a very effective strategy, and I don't need to tell you here how effective it is for both mood and anxiety and underlying mental health conditions that play a very integral role to chronic abdominal discomfort. And so exercise is a very important part of an overarching strategy. Stress modulation and coping skills are very important. And I'm just brushing over these. These are entire topics of complex discussion in and of themselves. And then some mental health support, behavioral health strategies, psychotherapeutic support, counseling, etc., to address some of the mental health underlying issues that can exacerbate and contribute to underlying abdominal pain. Finally, as I leave therapeutics to the very last comment, there are myriad therapeutic agents that can be tried, and these need to be tailored towards two entities in the gut. One is to augment motility. So we use certain agents if patients tend to be more constipated, and we will use other agents if they tend towards diarrhea. And the second honing focus for medications is pain modulation, all of which you are all experts in. And there are myriad drugs that we can try to augment pain control, all of which we focus on non-narcotic base. And one of the best drugs that I use is a tricyclic antidepressant, which has a number needed to treat of 4, Elavil or amitriptyline, nortriptyline, despyramine. All are fantastic drugs, and we use every day in our clinical practice and tend not to interact with some of the other antidepressants and anxiolytics that are widely used. So in collaboration with family physicians and specialists, therapies are a very important adjunct to this overarching multidisciplinary approach. So I would hope to leave you today with a few messages in and around the complexity of chronic abdominal pain and the different etiologies and pathophysiologic mechanisms that contribute to it. I think what's most important that I'm thrilled to see, close to 250 people that are interested in and care for patients with chronic pain. And because I believe that multidisciplinary management is the foundation of success for these patients, because the aim really is to help patients cope, help them manage the pain, and really improve their quality of life and decrease their acute and urgent healthcare utilization, keep them out of the emergency department where their care may not be the very best and the most appropriate. So this is a beautiful picture of where we camped last weekend in Kananaskis with my family. I'm so grateful for your time today. So I will turn it over to the moderator, and thank you so very much.